All right, everyone, we'll go ahead and get started. So that way we'll have ample time. So today we're going to have a fantastic grand rounds by Dr. David Carpenter. He did medical school here way back when we were talking about Clopton. Apparently they didn't used to have these rails. An accident had to occur and now they're present. So we had some good laughs about that. He said it's been renovated, which beyond me, but very interesting history of Clopton today. After medical school, he stayed here and did neurology residency, and he is now still here. He's a WashU almost lifer, where he is a professor of neurology and then the medical director of the Comprehensive Stroke Center. And today he's going to talk about the use of antiplatelet and antithrombotic therapies in stroke management. Let's welcome Dr. Carpenter.
Thank you. Actually, I'll just add a little bit to that. I'm not quite a WashU lifer. After I finished about 5 years after fellowship and some junior faculty stuff, I went off to private practice for about 12 years back at Mercy. And as things got really kind of hot in the field of stroke and they needed somebody to do clinical activity, I got a call from one of my former mentors, Bill Powers, who said, "Dave, do you think you might consider coming back to WashU?" Bad imitation, but so I'm back here as part of what I sometimes call the Great Washington University Recycling Program, or possibly a scene from The Godfather 3 of just when I thought I was out, they sucked me back in. Okay, so we're going to talk about antiplatelets and other antithrombotics in stroke. I don't really have any applicable disclosures. And so just a brief preview of kind of what we're going to be talking about. I'm going to try and have some semblance of organization to this because it really developed over time without necessarily that much organization. So I'm going to split it into sort of acute stroke and secondary prevention long term. And each one I'm going to be talking about either stroke in general or non-cardioembolic stroke in particular, and then kind of move to cardioembolic stroke. And because that potentially gets into at least 1 or 2 hours of talk in itself, I'm going to focus down principally on non-valvular atrial fibrillation, which is generally the most common cause by far of cardioembolic stroke. And so I can't help but think a little bit about where I started in all this process. I mean, back when I was a WUMS 3 starting out on the wards, my colleagues and I had a poetic law of the stroke workup and treatment, which was CT, LP, EKG, OT, PT, OTD, which was pretty much all that got done, really. We kind of thought by the time I started residency that aspirin was helpful for preventing stroke recurrence. Maybe the dose that was used back then was 650 milligrams twice a day. That would make most people keel over nowadays to think about that. And we had endless debates over, acute and chronic anticoagulation. And so we're going to talk a bit about sort of where all that ultimately landed. So for acute stroke, sort of in general, or focusing on non-cardioembolic stroke, some of the options which have existed over the years that I'm going to talk about were heparin, which was endlessly debated, aspirin, and then we're also going to talk a bit about newer agents, ticagrelor and combinations, aspirin plus clopidogrel and aspirin plus ticagrelor. Those have been relatively more recent options that have come online. So just to deal with heparin a bit briefly, I mean, the rationale for this always was it stops thrombus propagation, and so it might help prevent growth of an infarct. It was used a fair amount, particularly with people with so-called progressing stroke, despite the fact that thrombus propagation is only one of many mechanisms by which people who have a stroke may worsen after they're admitted. And there were anecdotal reports and very small limited case series that suggested that it might improve outcome. And also, I tend to think pejoratively that one of the reasons that heparin was such a popular option is that anything which requires constant monitoring and IV drip and can make you bleed to death must be good for you. There were a lot of studies eventually looking at heparin in the acute stroke setting, and it doesn't make sense to try and belabor these all. The first of these was a small series published in 1986 And together, all of these studies spanned anything from DVT prophylaxis doses to DVT and pulmonary embolism treatment doses of heparin, low molecular weight heparin, and heparinoids. All of these trials were negative except for one, this one, which interestingly was published at the same time as the NINDS TPA trial in the same issue of the New England Journal, which caused quite a stir, although it was replicated twice, both times really without any evidence of benefit. So these studies together pretty much put to bed the idea of acute heparin as a broad strategy for treatment of ischemic stroke, and also largely made treating TIA less popular as well. About the same time, people actually looked at aspirin in a randomized controlled fashion as an acute stroke treatment. And to the surprise of some, aspirin actually turned out to have a modest acute benefit when started within about 48 hours of the onset of stroke. And these data came from two studies. One was the International Stroke Trial, which also had an arm that looked at heparinization, and the Chinese aspirin stroke trial. Both of these, you'll notice, used relatively larger doses of aspirin, 160 or 300 milligrams a day. Both of them showed that there was a decrease in early recurrent stroke risk and also a modest decrease in early death. Okay, and so these two studies primarily are the driving force for why, as a stroke center, one of the things that we're required to track, and hospitals are required to track in general, is the percentage of patients with ischemic stroke who get aspirin starting within 24 hours or some other similar antithrombotic. It's also the reason why frequently at our center we start with 325 milligrams a day and then switch to lower doses either at discharge or on follow-up. Okay. So based on, these two studies encompassed about 40,000 patients. The estimates are that, aspirin prevents about 1 death or recurrent stroke per 100 patients treated. Not a huge treatment effect. On the other hand, aspirin is really pretty much dirt cheap. Okay. So on the other hand, although that's a small treatment effect in the first 2 weeks, if you extend that out to the first 6 weeks or more, it starts to get rather more noticeable. And this was something that was really only relatively recently published by a fellow by the name of Rothwell in England, who does a lot of really very nice meta-analytic studies of stroke and stroke treatment. He decided to look at what turned out to be acute treatment as well as some secondary prevention studies. Now, most secondary prevention studies in stroke really didn't enroll many patients right at the time of stroke because of trying to enroll enough patients, they would permit people to be enrolled up to 3 to 6 months after stroke. But when you cone down just to that population of patients who are treated very early, you can find that aspirin reduces the 6-week risk of recurrent ischemic stroke by about 60% in this meta-analysis. The greatest benefit turns out to be for patients with TIA or minor stroke, and it really kind of disappears with patients with severe stroke, and it's not clear in patients with moderate severity stroke. The benefit was greatest at the first couple of weeks, but continues to accrue up to about 12 weeks. And it also, in this meta-analysis, appeared to reduce recurrent stroke severity. So this study was partly done because of increasing interest in antithrombotic agents really in the very early period after a stroke. And that led to studies of a number of the other newer agents as acute treatment options. So we're going to talk a little bit first about ticagrelor. Ticagrelor, as you know, is an antiplatelet agent. It acts at the ADP receptor for platelets. It was tried as a single agent as an acute treatment against aspirin in the Socrates trial. Ticagrelor, similar to clopidogrel, if you want really early effectiveness, you kind of have to load patients with it. The primary endpoint for this study was an early endpoint at 90 days. It really showed that there wasn't really a proven benefit for ticagrelor over aspirin Bleeding complications were about the same. Ticagrelor also tends to be a bit more expensive than aspirin. And so this has not exactly taken the stroke world by storm, but it does show that ticagrelor is perhaps at least a reasonable option as a substitute for aspirin if people are, for example, aspirin allergic. Okay. Now, the recent development that is getting increasingly adopted is the use of acute dual agent antiplatelet therapy for acute stroke. There was a study initially published about 10 years ago called the Chance Study, which looked at this. And so this was looking at giving aspirin plus clopidogrel to patients with acute stroke within 24 hours of the onset of their deficit. And because there was an increasing amount of data that even by the time this study was designed, that really long-term therapy with dual antiplatelet therapy wasn't necessarily helpful, they decided to give this really for a fairly short period of time, 21 days. This showed that indeed, actually, if you add clopidogrel to aspirin, you wind up with a significant benefit in terms of about a 3.5% absolute risk reduction in early stroke compared to aspirin, without, in this study, an increased risk in concerning bleeding problems. Now, this study was performed exclusively in a Chinese population, and stroke in China isn't quite the same animal as stroke in North America and Europe. The Chinese patients tend to have a much higher risk of intracranial atherosclerosis as the cause of their stroke. So this wasn't really widely adopted, at least initially, although there was certainly interest in it. And so another study was done that was published about 5 years later called the Point Study. This one was done predominantly in North America and involved patients with minor ischemic stroke or high-risk TIA, which was really the same population as used in Chance. Minor ischemic stroke meaning NIH stroke scales of 0 to 3. And high-risk TIA, the risk stratification is done with something called the ABCD2 score, which is an attempt to identify, how much early recurrence risk there is in patients with TIA. And again, these patients were randomized to clopidogrel plus aspirin versus aspirin with a grouped endpoint of stroke MI or vascular death at 90 days. It was stopped early because in this study, actually, there turned out to be an excess in major hemorrhage in the dual antiplatelet therapy group. And so here's the curves, which are kind of inverted in comparison to how they were presented in Chance, again, showing that the clopidogrel plus aspirin group does significantly better. However, here there's a larger amount of problems with hemorrhage. Now, so the question was sort of like, why the difference? Is it just a play of chance, or were there differences that were considered to be important? The major differences were really that Point, they tended to randomize people somewhat earlier. The loading dose of clopidogrel was twice that was used in the Chance study. And the duration of continuation of the dual antiplatelet therapy was longer. That may have had an impact on it. Certainly, when they kind of looked at the time course of the estimated benefit of dual antiplatelet therapy, what they were able to find really was that almost all the benefit came within about the first 10 to 12 days. And after that, really, there wasn't really much of any difference in the risk of ischemic events, but the risk of major hemorrhages really continued throughout the period of treatment. And so what typically came of this is that we tend to use dual antiplatelet therapy on our stroke service for patients who meet these criteria, but we generally stick close to the Chance protocol. We tend to use the lower loading dose of 300 milligrams and continue it for 21 days and then stop after that, and usually continue either on aspirin or clopidogrel after that as a single agent. There is also a study that was done similarly of ticagrelor plus aspirin in comparison to aspirin. This one is used somewhat less frequently, but it has its benefits. This one was called the Thales study. I don't know how to pronounce these. Anyway, this accepted people with somewhat higher NIH stroke scales, and also, or people with high-risk TIAs. People with TPA or thrombectomy were excluded from both of these trials. You load with ticagrelor and continue with aspirin. This was done for 30 days. And here again, what they found was that there was a modest reduction in the risk of the primary endpoint, which was stroke or death in this particular study. There was, however, also some increase in severe bleeding. So although this has some overall benefit, it's not without some potential cost there. So this is very useful, for example, in people who have a slightly higher NIH stroke scale and therefore don't meet criteria for the CHANCE study, or in patients whom you suspect they may be clopidogrel non-responders. As some of you may know, clopidogrel is a prodrug. It has to be converted by the liver to its active form, and there is some genetic variants that make some people not really respond to clopidogrel. As it turns out, those are particularly higher in Chinese populations. And in the CHANCE study, they were able to demonstrate that if you looked at folks who had that variant where they don't respond, that they didn't respond to the dual antiplatelet therapy either. So to summarize a little bit about early therapy of cardioembolic stroke, I'm sorry. So I'll summarize that bit a little bit later, and I'm going to move on now a little bit to early antithrombotic therapy of cardioembolic stroke. Most of the data here pertains to non-valvular atrial fibrillation. Now, we know, and I'm sure most of you are familiar with, the idea that anticoagulation in the long run can reduce stroke risk in non-valvular atrial fibrillation. The question that I'm going to deal with now is, what about acute treatment? Early case series, back when I was a resident, there was a lot of interest in early anticoagulation of cardioembolic stroke because there was some low-level data in case series that suggested that the recurrence rate for non-valvular atrial fibrillation-related stroke might be extremely high as 15% in 2 weeks. As data began to accumulate on that, it became clear that that was probably an overestimate. The IST study, which was one of the studies that looked at heparin that I showed you earlier, had a fairly significant population of patients with atrial fibrillation. And what they found was that even in the control group, the recurrence risk in 2 weeks was about 5%, really 1/3 of what had been speculated upon. And that heparin really didn't help. And if you drilled down on that a little bit, what you found was that it decreased the risk of recurrent ischemic strokes, but unfortunately, it increased the risk of brain hemorrhages, which is one of the risks that you take when you anticoagulate a stroke early. There was another study looking at this that had an arm that looked rather specifically at non-valvular atrial fibrillation. This was dalteparin versus aspirin. And again, the recurrent stroke rate really wasn't any different. If anything, it trended to be a little bit worse in dalteparin. This was a relatively small, underpowered study relative to the IST group. And then as more studies began to look at this, this is from a meta-analysis that was published back in 2007, looking over a bunch of trials on cardioembolism or subgroups from larger trials of ischemic strokes. And basically, over the patients in this study, there really wasn't any influence of anticoagulation on ultimate death or disability. And again, this general trend of you get somewhat less recurrent ischemic strokes with somewhat higher symptomatic cerebral hemorrhages, which essentially wind up canceling each other out. So this is why generally we don't tend to be in a big hurry to anticoagulate stroke based on this kind of data in people with non-valvular atrial fibrillation. So to talk then, just sort of summarize a little bit about what we've gone over the past few minutes then. So acute anticoagulation really isn't any better than antiplatelet therapy for acute ischemic stroke, really, whether it's cardiobolic or not. Aspirin, when it started within 48 hours of hospitalization, reduces the risk of stroke or death within the first 2 weeks, and really by a much larger proportion within the first 6 weeks. Patients with minor stroke or high-risk TIA actually get some additional benefit out of short-term dual antiplatelet therapy, and after that, we generally go back to single-agent antiplatelet therapy, and we'll come back to that issue a little bit more in the second part of the talk. Acute treatment trials really have not shown a benefit from immediate anticoagulation versus aspirin for stroke related to non-valvular atrial fibrillation. Now, realizing, of course, they also don't show harm, although it's a little bit of a bad look when somebody hemorrhages on an anticoagulant that you started. But as a result of that, for example, if there's some other reason the person really needs anticoagulation, for example, they also have an acute DVT, or they have a pulmonary embolism, or they have acute coronary syndrome, and the cardiologists are asking, gee, what about, can we anticoagulate these people? We'll usually say yes, unless there's some factors present that make them especially high risk for anticoagulation in terms of cerebral hemorrhage. So now we're going to go on to the secondary prevention part of the talk here. And so again, we're going to talk a little bit about non-cardiobolic and then cardiobolic stroke. And so some of the issues or the candidates, if you will, that we're going to cover are aspirin clopidaril, aspirin dipyridamole, and also dual antiplatelet therapy with aspirin plus clopidogrel, because lots of patients are on that, because our friends in cardiology are frequently having people on that because of their stents or because of acute coronary syndrome. So there were multiple trials done of aspirin in secondary stroke prevention. Most of these trials enrolled patients from up to 3 to 6 months after their index stroke. And so they really don't encompass that acute period. When you're looking at meta-analysis of these issues, you need to be very careful to look at what kinds of studies they included, because I've seen at least 1 or 2 meta-analyses that, in my opinion, inappropriately lump both kinds of studies together and come to conclusions that are, I think, as a result, are not necessarily terribly helpful. So most of the early studies were done with sort of analgesic doses of aspirin. And then over time, really, people began to test lower and lower aspirin doses. So as a result of that, one of the arguments that came up when I had considerably less gray hair was, what's the best dose of aspirin, or is there an ideal dose of aspirin? And so there were at least 2 fairly large meta-analyses that looked at this. This is the more recent one, which kind of did a sort of a meta-regression of treatment effect as opposed to aspirin dose, and basically showed that the line of regression for this is not significantly different from 0. And that overall, over this whole span, aspirin reduces the risk of stroke, and that's stroke alone, by about 15%. Not a really large treatment effect. And there's some indications, really, that coronary artery disease, aspirin performs a bit better, unfortunately, than ischemic stroke. And so this is why, really, as far as long-term aspirin administration, we tend ultimately in most of our patients to switch down to 81 milligrams a day. In Europe, they have some pill formulations which are rather smaller, but 81 is the one that we tend to use quite a bit. One of the advantages of this is that the lower doses tend to have less side effects, particularly, what tends to be significant is less upper GI symptoms. There's a trend, which in this meta-analysis wasn't quite statistically significant, towards a reduction in GI hemorrhage. Of course, this is just at 300 milligrams. I don't think I have a similar slide for 81. So now we're going to talk, whoops, I went the wrong way. So now we're going to talk a little bit about secondary prevention in some of the other agents, and I'm going to talk a little bit about clopidogrel. As I mentioned, it's a prodrug. It gets converted to its active form by the liver. There's an isoenzyme there that has the potential to have a form which does not convert that very well. And so clopidogrel was tested for stroke and cardiac disease in a study called the Capri study. This was a very large study in which it was compared with aspirin in patients who had either stroke or an MI or peripheral arterial disease, and it had a lumped endpoint of MI, stroke, or vascular death. And as a single agent versus aspirin, what it showed was that for that lumped endpoint, it was modestly better. The risk reduction was only about 9%. The absolute risk reduction was about 0.5% per year over the duration. So really not exactly a stunning risk reduction. In addition, one of the things that has always been a bit of a head scratcher about the Capri study was that if you looked at the treatment effect in the different groups who were permitted to enter the study, what you found was that for reasons that nobody could really explain very well, stroke patients did about as well as the group as a whole. MI patients really didn't seem to have a treatment effect for clopidogrel, and peripheral arterial disease did somewhat better. So the study really was not powered to find individual benefit in these subgroups. So because of this, we still sometimes use in stroke clopidogrel by itself. Now, disclosure here, that's an off-label indication because clopidogrel is actually only approved to reduce the risk of stroke plus myocardial infarction and death, not stroke by itself. Okay. The cardiologists tend generally not to really use clopidogrel at all as a single agent. Some other issues, I mentioned the fact that it's a prodrug, which can be vulnerable to mutations of this isoenzyme. Also, proton pump inhibitors can block the conversion of clopidogrel to its active form. The least bothersome one of those is pantoprazole. You can test for allelic variants of this, and in fact, there's actually a rapid test which is used in China, and I'm not sure that's available in this country. And I mentioned that this is an off-label indication. So because of some of those vulnerabilities, rather than starting with clopidogrel in our stroke patients, but you'll see occasional stroke patients who wind up on clopidogrel if they've had problems with recurrent stroke, or particularly if they're aspirin sensitive. Another agent that's an alternative to aspirin is aspirin plus extended release dipyridamole. Dipyridamole is another antiplatelet agent. It's a phosphodiesterase inhibitor. Early trials of dipyridamole were in fact negative for risk reduction for stroke. It has a rather short half-life, so really if you're using it by itself, you have to dose it 3 or 4 times a day. Some folks came up with an extended release form, which was then put into practice and used in a number of studies, particularly in combination with aspirin. The 2 largest of these were called the ESPS2 study and the Aspirin study. And this is a meta-analysis of pretty much all of these together. These are the regular dipyridamole studies, which did not clearly show a benefit. These 2 are the ones which used extended release dipyridamole, which showed a benefit here. And they're much larger studies also, so they tend to contribute most of the data here. And so the dipyridamole, extended release dipyridamole plus aspirin has a modest benefit over aspirin, amounting to about a 1% per year absolute risk reduction in recurrent stroke in comparison to aspirin. Not huge, but it's significant. One of the reasons that you don't see aspirin dipyridamole used all over the place is a tolerability issue. People fairly commonly have problems with headache or GI problems such as diarrhea on it. And so in some studies, up to 25 to 30% of patients ultimately stop it because of one of those issues. So the other issue that came up was because of these absolute risk reductions, is one of these medications better than the other? And this was a furious argument for about 10 years between the manufacturers of these two drugs. And eventually the manufacturers of extended-release dipyridamole and aspirin paid for a very large study called the PROFESS study, which was designed to provide ultimate victory and demonstrate non-inferiority and possibly superiority of aspirin dipyridamole to clopidogrel. And without going into huge amounts of detail about the non-inferiority analysis, this is what they got, which was, as you can imagine, this was probably a somewhat disappointing result, okay? This is almost exactly the point of identity for the two treatment effects. And this was the non-inferiority margin, and the confidence intervals do not exclude that. So they couldn't say it was superior, and they couldn't actually even say that aspirin dipyridamole was non-inferior. And I have no idea how many people at the company were fired over the design of this trial. 20,332 patients. It was a huge study. Okay. Adverse treatment effects. Again, headache with permanent discontinuation was one of the most common side effects of aspirin dipyridamole. There was a question of some increase possibly in intracranial hemorrhage in this group, which was not seen in other studies. But it's one of the other reasons to be a bit hesitant, perhaps, about this medication. Nevertheless, it's still something which is on the market. It's still something that we'll sometimes use as an alternative in people perhaps who have recurrent events if they're just taking aspirin, and particularly if they might be non-responders to clopidogrel. So just to summarize that a little bit, which I think I already did, there were more dropouts in the aspirin dipyridamole patients. Now, of course, the other issue was, again, in our continuing efforts to give people more and more antithrombotics to try and prevent stroke, which is kind of a general trend over stroke prevention the entirety of my career, what about combining aspirin plus clopidogrel? Because, of course, the cardiologists have good data that this is somewhat helpful. They do it in the CURE study demonstrated that this was helpful in patients with acute coronary syndromes. It's also even more commonly, perhaps, a strategy that's used to prevent occlusion of drug-eluting stents. And so what about stroke? Well, there were at least a couple of studies that looked at trying to combine aspirin and clopidogrel long-term as a secondary stroke prevention strategy. They were the MATCH study, and there was an arm of another study of lacunar stroke called the SPS3 study that looked at combining these two. MATCH was a study actually of clopidogrel versus clopidogrel plus aspirin, and SPS3 was a study of aspirin versus aspirin plus clopidogrel. Both of these looked at endpoints that encompassed recurrent stroke. MATCH also looked at MI and vascular death. Both of these studies showed that there was no additional benefit. Both of these are long-term studies. You'll see this MATCH enrolled people up to 3 months after their index event, SPS3 up to 6 months after their initial event. So just to look at one of these study results, because I think you probably recognize what's likely coming here. If you look at all stroke recurrence, there really wasn't any benefit in SPS3. There may have been a trend towards slightly reduced ischemic stroke, but it was not significant. And likewise, there's sometimes in both this and MATCH, there was a trend that was not quite significant towards increased cerebral hemorrhages, which we call BAD. Both of these studies showed increased numbers of major hemorrhages in patients on clopidogrel, and death rates in the SPS3 study only, but not MATCH, were somewhat elevated in people on dual antiplatelet therapy. So this is why you'll sometimes see notes from us in a patient who comes to see us in follow-up or see us for the first time, if you're also following, where we will kind of say, from the stroke standpoint, this person now does not have a reason to be on dual antiplatelet therapy. If a reason to stop this for other reasons comes up, it's reasonable for them to be on single agent antiplatelet therapy, because we recognize that cardiologists may have their own reasons for having people on two agents. So clopidogrel or aspirin dipyrnol provides some modest benefits over aspirin in secondary prevention. Clopidogrel is vulnerable to some of these difficulties, and aspirin dipyrnol a bit vulnerable to tolerability. Combining aspirin and clopidogrel in secondary prevention studies long-term doesn't really reduce the risk of all stroke. It does increase hemorrhagic complications. The acute short-term studies that I talked about earlier, like Chance, Point, and Thales, on the other hand, are rather different matter, and you kind of need to keep those a little bit separate in your thoughts. Okay, so now I'm going to move on to secondary prevention of stroke in cardioembolic diseases. And this is just a slide listing some of the agents, some of the underlying cardiac problems which are known to increase the risk of cardioembolic stroke, atrial fibrillation being the one responsible for most of these, but also myocardial infarction, left ventricular dysfunction, left ventricular thrombus, and so forth. Those are certainly potential causes that we look for on the stroke service, but they're actually much less common than atrial fibrillation. These are the ones which actually have some data behind them that they have some benefit from long-term anticoagulation. And as I mentioned, I'm going to really mainly focus on atrial fibrillation because that's where really the bulk of the data is. Okay, so what about antiplatelet therapy for atrial fibrillation-related stroke? Well, there's actually data that, particularly from meta-analysis, that antiplatelet therapy with aspirin has some modest benefit in reducing the risk of cardioembolic stroke in aspirin. The treatment benefit is not very large here, so it comes out at a slightly greater, perhaps, than 20% relative risk reduction, but it's certainly present in comparison to placebo. On the other hand, the risk reduction for anticoagulation, and many of these trials, the placebo-controlled trials, are all with warfarin, show a considerably greater benefit. And so now we're talking here about a risk reduction of over 50% for recurrent stroke in patients with atrial fibrillation treated with warfarin. Okay, so that's a huge risk reduction. It's much greater than almost any, well, really than any of the other medical treatments that I've shown you. It is almost as great as the risk reduction for symptomatic carotid endarterectomy in people with high-grade stenosis. So one of my running jokes with our residents is that, surgery for symptomatic carotid endarterectomy is the 2,000-pound gorilla of stroke prevention. And this is its slightly lighter weight cousin. Okay. Now, nobody likes anticoagulation, however. Why? Because it makes you bleed. It's bad. There are clinical prediction rules to try and stratify the risk of stroke in people with non-valvular atrial fibrillation. The one that seems to have gained ascendancy is the CHADS-VASc score. The CHADS-VASc score, in comparison to the CHADS-2 score, mainly has the advantage of being a little bit more granular in patients who are relatively low risk for atrial fibrillation. These are the typical annual stroke risks for different CHADS-VASc scores. The most common recommendations tend to be that if your CHADS-VASc score is 0 to 1, or some recommendations 0 to 2, perhaps you're just as well off having people on aspirin and avoiding the additional difficulties of having people on anticoagulation. The problem is even at low CHADS-VASc scores, you still have people who have atrial fibrillation-related strokes, and those unfortunately tend to be, on average, rather nastier strokes with higher disability and mortality. Okay, so warfarin is helpful. On the other hand, more recently have appeared on the scene the non-vitamin K oral anticoagulants, which sometimes get called DOACs or NOACs. They're the most commonly used ones that we tend to be Xarelto, apixaban, and dabigatran. They were the first three really to become approved. I'm not going to try to go through all of those major trial results, but all of those medications were compared in their performance to warfarin. The trials of dabigatran and apixaban generally showed superiority over warfarin for the reduction of the risk of stroke. And apixaban showed actual decrease in risk of hemorrhage compared to warfarin as well, whereas dabigatran was also superior at low dose, but non-inferior at its more typical 150 milligram dose. Okay. Okay. Yeah, apixaban was also the only one of the first four originally that was not inferior to warfarin when it came to GI bleeding. Okay. So advantages of these medications are somewhat obvious. They don't require dosage adjustments. They have, particularly in the case of apixaban, lower bleeding risk. They're fixed dosing. They don't have nearly as many dietary or drug interactions. On the other hand, they also tend to be more expensive. Arguably, you know, it can be viewed as potentially a disadvantage that they have a shorter half-life of action, which means that if you miss a single dose or miss a couple doses, you may have much more degradation of efficacy than if you miss a dose of warfarin. One of the biggest problems really in practice tends to be that they're more expensive, particularly with a population of patients who are on Medicare and may have trouble covering their medication. So as I talked about, acute stroke studies didn't really show a benefit for anticoagulation as an acute treatment, although those really applied primarily to medications like heparin. So there's an issue, particularly with the newer medications, of trying to figure out, okay, we know these medications are helpful in the long term. When should we start them in patients who've just had a stroke? And this is a situation that comes up not very uncommonly. Either we discover atrial fibrillation in a patient who's not been known to have it on our stroke service. That happens 10 to 15% of our patients. Or a patient who was previously thought to be low risk has a stroke, and now it's time, since having a stroke definitely increases your risk for having future problems. Now we have to grapple with starting anticoagulation. Well, as I mentioned, there's concern for converting an infarct to a hemorrhage. There's a number of potential things which influence the risk of that. The two which are most consistent tend to be the size of the infarct, which larger infarcts are somewhat more prone to early hemorrhagic conversion, and also uncontrolled hypertension, which is actually somewhat less consistently seen in the literature. There's actually been a lot of interest in trying to develop these data, and there are a couple of randomized trials that have been published recently, and more that are in progress trying to sort this out. This one is a study published about a year ago called the Timing Study. In this study, patients with atrial fibrillation and stroke were randomized to just either early start versus delayed, early being less than 4 days. They didn't really attempt to stratify their patients at all for size of infarct. And in contrast to some of the earlier data on this, they really used NOACs only. 50%, the most commonly used NOAC was apixaban in this study. And what they found was that for early starts, early starting seems to be non-inferior. It wasn't clearly superior, although you see there's a weak trend here, perhaps, towards benefit of an early start. Okay. So this is useful to have because some earlier recommendations that were based primarily on heparin data or aspirin data suggest delaying as long as 2 weeks, which is a real problem because the patient may be off service by that time, and now you're trying to figure out how to start anticoagulation when the patient is either in rehabilitation or at a nursing facility or otherwise out of your care. And I can tell you from experience that does not necessarily work very well. So this suggests that many of the patients actually can be started at the time of discharge or shortly afterwards. Another more recently study is the Elan Study. And I just have to say parenthetically that neurologists really suck at names for studies. And the cardiologists have gotten much better people working on this. I mean, really, the one I mentioned earlier, the CURE study, there's a study name for you. Okay, So Elan, this one randomized patients to early versus late, and they have a rather confusing way of defining early versus late because it's different depending on the size of your strokes. You know, for early was less than 48 hours if you had a small to moderate stroke, and at day 6 or 7 if it was severe. Late, there were 3 different start dates depending on how big your stroke was. Primary outcome that they used was stroke, embolism, major bleeding, hemorrhage, or vascular death. So they basically tried to lump every possible relevant endpoint into one. They weren't really planning at all to try to do any kind of superiority or inferiority analysis. They basically said, we just want to develop some data on what the risks are. And so what they found, they did at least kind of establish some confidence intervals here. And again, for the primary outcome event, there wasn't a statistically significant benefit for earlier starts, but that was the trend. And so at least it looks like based on this data, there is an argument that, again, earlier starting is reasonable, even though not necessarily essential in patients on NOACs. So anticoagulation markedly lowers the risk of stroke in patients with atrial fibrillation. There are multiple studies which demonstrate, sorry, I missed the fact that I haven't summarized yet here. Going to move on to a slightly different topic here now in the line of treatment of atrial fibrillation related stroke. As we mentioned, anticoagulation markedly lowers the risk of stroke in patients with atrial fibrillation. It's a big treatment effect. There are multiple studies, on the other hand, that have demonstrated that anticoagulation is relatively underutilized. That's despite the fact that, that the benefit is preserved in the very elderly, which is one group of people that people are somewhat hesitant to anticoagulate. And also, there are QI data that were developed by Dr. Gage of the medicine department here, as well as Mike Rich, that show that even patients who are considered relatively high fall risk still have a benefit, provided that their risk of having stroke is high. And part of the reason for that appears to be that the people who are high fall risk also have a higher risk of ischemic stroke. Okay, so, but the problem is, as I mentioned, everyone's very hesitant about anticoagulation because of hemorrhage complications. So I want to just mention that there is a fibrillation also. Our friends in cardiology have some devices which can be used to occlude the left atrial appendage. The left atrial appendage is where about 90% of emboli come from in people with non-valvular atrial fibrillation. The original problem with the devices that are approved in this country predominantly are called the Watchman devices. The original one still required about 3 months of anticoagulation, which is a bit of a problem if you're trying to get people off of anticoagulation, that you're still going to have them on it. However, there's a more recent iteration called the Watchman Flex, which only requires dual antiplatelet therapy early on. Okay. There are some procedural complications, but the big payoff of this is that use of these devices allows you to have the risk of stroke reduction that is about similar to warfarin without having to be on warfarin. If you drill down through this data, you find that it appears that where this comes from is partly a reduction in the risk of hemorrhage, because these people aren't on warfarin, and that there may be a slight trend toward, there's a trend towards increased risk of ischemic stroke, but still, both kinds of stroke are important, and the overall risk is similar, and we know that warfarin is certainly better than nothing. So I think there's a strong argument if you have patients who you're hesitant to anticoagulate, it's well worthwhile involving interventional cardiology to see if perhaps they're a candidate for an atrial appendage occlusion device. They're currently approved primarily for people with CHA2DS2-VASc scores of 3 or greater. There are currently some studies that are ongoing comparing these to NOACs and how they perform, because the original studies really compared to warfarin. Okay, To sum up then, anticoagulation is highly effective to reduce the risk of stroke and atrial fibrillation. Among the NOACs, dabigatran and apixaban were shown to actually be superior to warfarin in reducing the risk of stroke. The optimal start window initially is still unclear, but appears to be trending towards 2 to 4 days, at least for smaller strokes. And just another take-home point, anticoagulation, it tends to be underutilized. If you find you have a patient with who has atrial fibrillation and a relatively high stroke risk, left atrial appendage closure is well worth considering. So I'd like to thank you all for managing to stick it out to the end of this talk. You can consider it a major achievement. And so I'm happy to take questions at this time. That is a superb and really thorny question. And it's almost another hour. But so studies that have tried to look at this, it gets really kind of confusing, okay? Because as you point out, there's a popularity for using long-term monitoring in patients who had a stroke looking at atrial fibrillation, okay? And the answer is, we're not really sure, okay? For people who've not had a stroke, the cardiologists have some pacemaker data that suggests that for stroke-naive patients, it may take as much as 24 hours of atrial fibrillation at a stretch to really increase your risk of first stroke. The problem is everybody gets much more nervous when people have already had a stroke. And there is some data that, or there's a lot of concern that part of what leads to stroke is not necessarily the atrial fibrillation itself, but possibly some atriopathy, if you will, that exists that leads to the atrial fibrillation. So in the setting of somebody who's already had a stroke, people's thresholds to anticoagulate tend to be much lower, but nobody really knows yet what the right threshold is. It is clear that you can find quite a bit more atrial fibrillation with longer-term monitoring. But as you point out, particularly if you put an implantable monitor in somebody, you may find a few seconds of atrial fibrillation over 6 months. Well, you know, this tends to be sometimes the discussion between the cardiologists and us about when do we really think that's significant. But the threshold does tend to be significantly lower for anticoagulating those folks. Yeah. I think that the population of folks that were studied in North America was a mix of patients. I mean, there's been increasing efforts to try and enroll applicable minority patients, you know, African American, Hispanic, and so forth, into these studies. And so I think they're as reasonably generalizable as we can get. I don't think they were ever designed to try and do subgroup analyses of each of those populations, however. But I think that the two studies together showing really pretty, you know, fairly similar results suggest that at least for people who are not clopidogrel non-responders, that it's a pretty durable treatment effect. Super. Thanks very much.